Imagine a 19-year-old hockey player, right? He takes a brutal check into the boards. He drops to the ice, out cold for, I don't know, maybe 30 seconds.
Sounds like a standard sports vignette.
Exactly. But then he wakes up, he skates to the bench, he shakes it off, and tells the athletic trainer he feels completely fine. He's talking, joking around, drinking water.
Right, the classic presentation.
Yeah, but inside his skull, a torn middle meningeal artery is just pumping high-pressure arterial blood into a closed space second by second. This is the terrifying ticking clock of the classic lucid interval.
It really is terrifying.
It is. And if the ER physician doesn't recognize what's happening beneath the surface, well, that patient might be dead in an hour. We'll be breaking down all major concepts covered on the exam. Welcome to this deep dive.
Glad to be here.
We are putting on our MCCQE reviewer hats today to help you, the Canadian medical student, master your neurology exam prep. And we are basing today's discussion on reliable StatPearls articles. But please remember, this is for medical education and exam review purposes only. It is not medical advice. Clinical decisions must always involve a qualified healthcare provider.
Absolutely. So our mission today is section S08 Neurology, specifically traumatic brain injury. But I want to be clear, we aren't just going to read a list of symptoms for you to memorize.
Nobody wants that.
No, because the MCCQE doesn't test your ability to recite a textbook. It tests your ability to understand the mechanical and the biological why behind the clinical presentation.
Right, because if you understand the physical rules governing the brain, you really don't have to memorize the symptoms of a subdural hematoma or like the long-term psychiatric fallout of a concussion. You can just deduce them.
Exactly. You can work backward from the physics.
So I think the best place to start is looking at the playing field itself. The epidemiology, the demographics of who gets these injuries really tell a story.
They do. It's a very specific pattern.
Yeah, you've got this classic bimodal distribution. A massive spike in older adolescents, ages 15 to 19, and then another distinct peak in adults 65 and older.
And with a 2-to-1 male-to-female ratio across the board.
2 to 1. Which makes sense.
It reflects the mechanisms of injury perfectly. I mean, that adolescent demographic is driven by sports, motor vehicle accidents, and, well, risk-taking behaviors associated with a frontal cortex that's still developing.
Sure.
But then the curve drops off, only to spike again at age 65.
Yeah.
And the mechanism changes entirely.
Right. It's not football tackles at 65.
Exactly.
Yeah.
And the elderly population, it overwhelmingly falls. And compounding those falls with these physiological changes, things like brain atrophy and the widespread use of anticoagulant medications.
Right. The blood thinners.
Yeah, those turn minor bumps into life-threatening bleeds.
Well, to understand why any of these bumps or bleeds are life-threatening, we have to talk about the physical constraints of the skull. I hear the Monro-Kelly hypothesis tossed around constantly on the wards.
It's the foundation of everything we're talking about today.
It really is. The standard analogy is the packed suitcase, right?
Yeah.
You try to force an extra pair of shoes into a hard-shell suitcase, and something else has to get crushed.
Right.
But honestly, I think a better way to look at it is trying to inflate a balloon inside a solid steel safe. The safe is the cranium. It's rigid. It does not expand. And inside, you have exactly 3 things.
Brain tissue, cerebrospinal fluid, and blood.
Exactly.
And the Monro-Kelly doctrine states that the total volume of those 3 components must remain absolutely constant.
Because the safe won't stretch.
Right, the safe won't stretch. So if you introduce a new mass, like that inflating balloon, which in clinical reality is a hematoma, the body has a problem. To prevent a catastrophic spike in intracranial pressure, one of the original 3 components has to be squeezed out.
So what leaves first?
Well, the body usually tries to push cerebrospinal fluid down into the spinal canal first, and then it squeezes venous blood out.
Just to make room.
Yeah, but these compensatory mechanisms exhaust very quickly.
And once that compensation fails, the pressure inside the safe just skyrockets.
Yeah.
Which leads to the core equation they hammer into us for the boards. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure.
TPP equals MAP minus ICP.
Right. I used to just memorize that for multiple choice questions, but mechanistically, what is actually happening to the brain tissue when that ICP number goes up?
Think of it as a fluid dynamics problem. Your mean arterial pressure, your MAP, is the forward driving force of oxygenated blood trying to push its way up into the brain.
Okay.
But that blood has to enter the closed safe of the skull. If the pressure inside the safe, the ICP, is higher than the pressure of the blood trying to get in, the blood hits a literal pressure wall.
Oh, wow. It just can't enter.
It can't enter the brain. your cerebral perfusion pressure drops to 0.
So the patient doesn't necessarily die from the physical crush of the blood clot itself.
No.
They die because the high pressure in the room prevents fresh, oxygenated blood from entering, leading to widespread secondary cerebral ischemia.
The brain starves.
The brain starves. That is so wild.
And that is the ultimate pathology we are fighting. Every single management strategy in acute head trauma, from elevating the bed to drilling a hole in the skull, is solely designed to lower the ICP so that the arterial blood can overcome the resistance and keep the brain tissue alive.
So we have this rigid steel safe, but what happens when the physical impact isn't strong enough to burst a pipe and create a massive blood clot, but instead it just violently shakes the entire safe?
Ah, right.
This brings us to mild TBI, or concussions, which make up like a massive 80% of all cases.
Yeah, the definition of a concussion is crucial for the exam. It is a transient altered mental status ranging from brief confusion all the way to a full loss of consciousness following an acceleration-deceleration force. But, importantly, without gross structural damage.
Without it, okay.
You aren't going to see a massive hematoma pushing the ventricles to the side. The damage is entirely microscopic.
Which brings up a classic MCCQE trap. A patient comes into the ER after a car accident. They bumped their head, they were confused for maybe 10 minutes, but now they seem mostly okay. As a medical student, the knee-jerk instinct is to order a CT scan of the head just to be safe.
Of course.
But why is a routine CT usually completely useless for diagnosing this microscopic damage, specifically diffuse axonal injury, or DAI?
Well, a standard CT scan is basically taking an X-ray slice of tissue densities. It's looking for macro-level architectural disasters. Big white pools of blood, fractured bone, shifted brain structures.
The obvious stuff.
Exactly. But diffuse axonal injury doesn't alter macroarchitecture. It destroys the microarchitecture.
Yeah.
To understand why, you have to look at the composition of the brain. You have gray matter on the outside, which is mostly neuron cell bodies, and it's highly fluid.
Right.
Then you have the white matter deeper inside, which is the long axons, heavily insulated with fat, myelin.
So they have completely different densities.
Completely. When the skull rapidly accelerates and then suddenly stops, the brain kind of sloshes around inside. And because the gray matter and white matter have different densities, they decelerate at different rates.
Oh, I see.
Imagine a train slamming on the brakes. The heavy cargo cars in the back smash into the lighter passenger cars in the front. Inside the brain, the gray and white matter slide past each other, creating massive shearing forces right at the junction where they meet.
So the axons crossing that junction get stretched and twisted like a wrung-out towel.
And that stretching physically breaks the neuronal cytoskeleton. It tears open the cell membrane, which instantly ruins the cell's carefully balanced electrical gradients.
Which lets everything in.
Right. Calcium, which is highly concentrated outside the cell, suddenly floods in. And this massive intracellular calcium flood is toxic. It causes the axon to swell, detach from its target, and trigger a cascade of cell death known as apoptosis. On autopsy, this looks like diffuse laminar necrosis.
Sure.
But on a Tuesday night in the ER, a CT scan cannot see a calcium flood at the cellular level.
It's just not designed for it. To actually see those broken white matter tracks, you'd need advanced imaging down the road, right?
Yep.
Like diffusion tensor imaging, which maps how water molecules move along the axons, or maybe a functional MRI.
Exactly.
I want to touch on the ultimate nightmare scenario with mild TBIs while we are here. Second impact syndrome. It's a favorite on pediatric and sports medicine vignettes.
Oh, definitely. It typically occurs when a young athlete sustains a concussion, their axons are swollen and struggling to recover, and they return to play too early.
Before the brain has reset.
Yeah, and if they take a second hit during this vulnerable metabolic window, the brain just loses its ability to auto-regulate its own blood supply. It triggers rapid, malignant cerebral edema.
Malignant swelling.
The brain swells catastrophically fast, often leading to uncal herniation and death within minutes. It underscores why the return-to-play protocols you study are so rigid.
They aren't just suggestions.
Not at all.
Let's shift gears a bit. We've covered the microscopic shearing. But if the forces are strong enough to tear vessels and cause gross structural damage, we enter the territory of extraaxial hematomas and contusions.
The bleeds.
Right, the bleeds. The board exam loves to make you differentiate these based on clinical presentation and CT findings. Let's start with the epidural hematoma, the EDH, which is what our hockey player had in the opening hook.
The epidural hematoma is an arterial bleed, usually caused by a direct blow to the side of the head. The skull fractures, typically at the aterion, which is the thinnest part of the temporal bone, and it slices open the middle meningeal artery sitting right underneath it.
Just slices it right open.
Yeah. And because it is arterial, the blood is under high systemic pressure. It rapidly, forcibly peels the duramater away from the inside of the skull.
And that high pressure is what creates that lucid interval.
Yeah.
The patient gets knocked out by the initial concussion. They wake up because their brain hasn't suffered massive crush injury yet.
Right, they feel okay for a minute.
But over the next hour, that arterial hose is pumping blood into the closed safe, rapidly eating up the compensatory mechanisms we talked about earlier until the pressure spikes and they precipitously lose consciousness and herniate.
Contrast that rapid arterial disaster with the subdural hematoma, the SDH. This is a venous bleed. It's caused by the tearing of bridging veins that travel from the surface of the brain across the subdural space to the dural venous sinuses.
Which brings us back to the demographics. Why is the SDH so classically tested in elderly populations or chronic alcoholics?
It comes down to brain atrophy. As the brain ages or shrinks from chronic alcohol use, it actually pulls away from the inner surface of the skull.
And it gets smaller.
Exactly. And this physical shrinking puts significant tension on those bridging veins. They are pulled taut, like violin strings.
Just waiting to snap.
Exactly. It takes very little force, a minor fall from standing, or even just bumping their head on a cabinet to snap one of those taut veins.
And because it's a venous bleed, it's under very low pressure compared to the arterial EDH. It oozes slowly.
Very slowly.
So the patient might not show serious neurologic symptoms for weeks. They present to the clinic a month after a minor fall with gradual confusion or hemiparesis, and the scan shows a massive, dark, chronic collection of blood that has been slowly accumulating all that time.
We also need to differentiate contusions, which are essentially bruises on the brain tissue itself.
Yeah.
You have coup injuries at the site of the impact and contra-coup injuries on the complete opposite side.
And what is highly testable here is where those contra-coup injuries almost always happen, right? The basifrontal lobe and the anterior temporal lobe.
Yes.
And it's because the internal base of the skull isn't some smooth bowl, it's covered in jagged, bony ridges. When patient falls backward and hits the back of their head, the coup injury, the brain rebounds forward and literally scrapes and smashes against those rough, bony prominences in the frontal and temporal fossa.
Which is a perfect segue to how we differentiate the final major bleed, the traumatic subarachnoid hemorrhage. The exam vignette will present a patient with blood in the subarachnoid space. The question is, how do you know if it's from trauma or a ruptured aneurysm just by looking at the scan?
I always get tripped up on this exact scenario
because
both present with subarachnoid blood, but the management pathways are wildly different. How do we spot the difference anatomically?
You look at where the blood pools. Traumatic SAH happens when the small capillaries on the surface of the brain tear from impact or from scraping against those bony ridges you mentioned.
Okay.
Therefore, you will typically see the blood accumulating over the convexity of the brain, the outer upper surface right near the skull. On the other hand, aneurysms usually happen in the circle of Willis, which is deep at the base of the brain. So if the SAH is aneurysmal, the blood tends to pool down low in the basal cisterns.
Wow. Okay, so convexity for trauma, basal cisterns for aneurysms. That is a massive clinical differentiator. Now, let's assume the patient survives the acute phase. The bleeding is managed, the pressure stabilizes, and they are discharged.
We enter phase 2.
Right. The MCCQE heavily tests the long-term neuropsychiatric complications that present months or even years later. These are the invisible scars of TBI.
The physical recovery is often just the beginning. Patients frequently develop post-concussion syndrome. This includes somatic complaints like chronic headaches, vertigo, and light sensitivity. But the cognitive and psychiatric impairments are what truly derail their lives.
Yeah, working memory is notoriously impaired, right?
Very much so. And the literature shows high rates of clinical depression, up to 18% developing substance abuse disorders to self-medicate, and nearly a quarter displaying severe PTSD symptoms.
What really jumps out from the StatPearls sources is frontal lobe syndrome. It occurs in up to 23% of adult TBI patients, almost 1 in 4.
It's a huge number.
It is, and this ties directly back to what we just talked about, the frontal lobes taking the brunt of the contra-coup damage against the jagged base of the skull.
The frontal lobe is the seat of executive function, impulse control, and your social filter. When it's structurally damaged, you see a profound shift in personality. The patient develops a labile effect, laughing one minute and raging the next.
Totally unpredictable.
Right. They exhibit aggressiveness, poor social judgment, perseveration, and often highly inappropriate or lewd behavior. Families often report that the patient is simply not the same person they were before the accident.
That is tragic, but it makes anatomical sense. What I found genuinely terrifying for a clinician is another syndrome mentioned in the sources, psychotic disorder following TBI or PDF TBI. It presents with paranoid delusions and auditory hallucinations, which sounds exactly like schizophrenia.
It looks identical on the surface.
But the latency period, the time between the head injury and the onset of psychosis, is 4 to 5 years.
It is a massive diagnostic trap. Imagine a 25-year-old patient comes into your clinic hearing voices. If you just take a standard psychiatric history, you diagnose primary schizophrenia and start antipsychotics.
Right.
But if you dig deep and find out they were in a severe rollover car crash 5 years ago, it changes your entire conceptualization of the disease.
Because the tragedy of missing that history is that treating it as primary schizophrenia completely misses the structural reality of their brain.
Exactly. PDF-TBI has an additive effect on executive dysfunction. A patient with primary schizophrenia might struggle with disorganized thought, but a PDF-TBI patient has profound underlying semantic and executive deficits from widespread axonal shearing years prior.
So the psychosis is secondary to organic structural brain damage.
Yes. The antipsychotics might quiet the hallucinations, but they do nothing to address the severe cognitive rigidity caused by the TBI.
Speaking of overlapping symptoms, it must be incredibly difficult to distinguish between the biological effects of the brain injury and comorbid PTSD. I mean, irritability, sleep dysfunction, these happen in both. How do you tease out what is structural damage versus what is a trauma response?
Advanced functional imaging like brain perfusion SPECT is incredibly useful here. SPECT measures actual cerebral blood flow. Because TBI fundamentally destroys tissue, it generally presents on a SPECT scan as hyperperfusion decreased blood flow, essentially dead or dormant zones.
Makes sense.
But PTSD, however, is a state of severe hypervigilance. The brain is stuck in a threat response loop. So PTSD shows up as regional hyperperfusion, particularly in the limbic system, basal ganglia, and prefrontal cortex. The TBI brain is underactive, but the PTSD brain is overactive.
That distinction completely alters the therapeutic approach. One quick clinical pearl from the sources regarding sleep dysfunction before we move on the exam loves timelines. Immediately following a head injury, the sleep architecture is disrupted such that the patient has a terrible time falling asleep and wakes up constantly.
Insomnia.
Yeah. But fast forward a few years, and the paradigm flips entirely. Excessive somnolence, or sleeping too much, becomes the dominant clinical feature.
Knowing how devastating these long-term psychiatric cascades are, and how rapidly the Monroe-Kelly physics can crush the brainstem in the short term, it all underscores the absolute urgency of the initial ER management. How do we stop this domino effect the second a severe TBI rolls through the trauma bay?
I look at the acute management protocols as a descending ladder of interventions. You are progressively taking more aggressive steps to lower that intracranial pressure. The top of the ladder is beautifully simple. Elevate the head of the bed to 30 degrees.
Right. It utilizes simple gravity to promote venous blood drainage out of the cranial vault via the jugular veins, decreasing the total volume inside the rigid safe.
Step 2 is transient hyperventilation. You put them on the vent and breathe them fast. But wait. Blowing off CO2 causes systemic cerebral vasoconstriction. If our ultimate goal is to maintain cerebral perfusion pressure and deliver oxygen to the brain, doesn't squeezing the blood vessels shut just starve the brain of oxygen faster?
It is a precarious balancing act. You are correct that it causes vasoconstriction. But in an acute herniation crisis, the sheer volume of blood in the skull is causing the lethal pressure spike.
Okay.
By hyperventilating the patient, you constrict the vessels, which dramatically reduces the volume of arterial blood taking up space in the skull, dropping the ICP. But it is strictly a temporary bridge. You only do it to buy yourself time to get them to the OR, because prolonged vasoconstriction will absolutely cause the secondary ischemia you were trying to avoid.
The next rung down the ladder is hyperosmolar therapy, utilizing agents like mannitol or hypertonic saline.
This is pure chemistry. You infuse a highly concentrated solute into the bloodstream. Because it cannot cross the blood-brain barrier, it creates an osmotic gradient.
Like a sponge.
Literally like a sponge, drawing excess water out of the swollen, edematous brain tissue across the barrier and into the vasculature where it can be peed out. The brain physically shrinks, lowering the ICP.
If that fails, we drop into the intensive medical interventions. One of the most fascinating is therapeutic hypothermia, cooling the patient's systemic temperature down to 34 or 35 degrees Celsius. What is actually happening at the cellular level when we chill the brain? Why does cold save neurons?
It freezes the cascade of destruction we discussed earlier. When tissue is crushed or sheared, the body mounts a massive post-traumatic inflammatory response. Immune cells rush in, cytokines are released, and the blood-brain barrier breaks down, causing massive fluid leakage and edema.
And cooling stops that.
Hypothermia slows down all metabolic processes. It physically tightens the blood-brain barrier, preventing that fluid leak, but most importantly, it blunts the release of glutamate.
Glutamate is the brain's primary excitatory neurotransmitter.
Yes. When brain cells rupture, they dump their intracellular stores of glutamate into the surrounding environment. This causes neighboring healthy cells to become wildly overstimulated. They fire their action potentials uncontrollably until they exhaust their ATP and die, a process called excitotoxicity.
Like putting a car in neutral and pushing the gas pedal to the floor until the engine sees it.
Exactly. Cooling the brain puts a metabolic brake on that excitotoxicity.
The sources also note hyperbaric oxygen therapy, or HBO2, as a potential adjunctive treatment. By delivering oxygen at supraphysiological pressures, you can force oxygen tension in the brain tissue up over 200 millimeters of mercury. This improves cellular oxidative metabolism and lowers toxic lactate levels by about 13%. But as the data notes, it's a graduated effect, not a magic bullet for a massive acute bleed.
Which brings us to the bottom of the ladder. If all medical management fails to control the pressure, you move to surgical measures. Right. The neurosurgeon must physically evacuate the intracranial hematoma. And in refractory cases, they perform a decompressive craniectomy. They literally remove a large flap of the skull bone and leave it off, finally giving the swelling brain room to expand outside the rigid constraints of the cranial safe.
As for predicting how a patient will fare after all of this, the single most important clinical indicator for the exam is the initial Glasgow Coma Scale, or GCS. If the vignette patient arrives with a GCS of less than 12, it is a massive red flag. It indicates a high probability of a long, arduous recovery fraught with the residual neuropsychiatric deficits we discussed.
To tie a bow on everything you need to take into test day. First, the Monroe-Kelly doctrine drives all pathophysiology and acute management. The rigid box means volume increases cause pressure increases, which ultimately drops the cerebral perfusion pressure and starves the brain.
Crucial point.
Second, remember the anatomical differentiator for subarachnoid hemorrhages. Convexity blood implies trauma. Basal cistern blood implies aneurysms. And third, keep a high index of suspicion for delayed psychiatric presentations. A personality shift from a damaged frontal lobe or the 4 to 5 year latency for psychotic disorders following a severe impact.
Understanding the mechanisms, the physics of the skull, the cellular calcium flood of axonal shearing, the fluid shifts of hypertonic saline is infinitely more reliable than rote memorization when you're sitting in the exam room. I want to leave you with one final thought to ponder as you review your notes. Right now, emergency neurology relies heavily on the clinical guesswork of the Glasgow Coma Scale, watching a patient's eyes open or seeing how they move their arms to guess how badly their brain is damaged.
It's surprisingly low tech.
Very. But based on the toxicokinetics research we touched on today, imagine a near future where we don't have to guess. Imagine if a paramedic could run a simple point-of-care test on a drop of cerebrospinal fluid for specific biomarkers. If we could instantly measure the levels of CGN N-terminal kinase, interleukin-1 beta, or the exact concentration of toxic glutamate, we would know exactly which apoptotic pathways are activating in real time.
That would be incredible.
It would completely revolutionize triage, moving us from macroscopic observation to microscopic precision before the patient even reaches the hospital. Keep studying hard, trust the physiology, and we'll see you on the next deep dive.